Welcome back to Ask Dr. Mingle. It's great to see you again. I'm Dr. Dan Mingle, family physician, founder and CEO of Mingle Health. I'm here to answer your questions about value-based care and value-based payment. This is the second production in this set about the 2026 proposed rule. I'm calling it an elemental approach. I've divided into short, digestible sections. You can just drill in on those areas in which you're interested. Previously, I've recorded an orientation to the rulemaking cycle, including other resources to help you understand it better, dig deeper into the reasons for proposals. In this presentation, I'll be talking about the general basic quality payment program, specifically MIPS and alternative payment models. In the third installment, we'll talk about MIPS value pathways. The fourth, we'll get into specifics about Medicare's shared savings program. The fifth, we'll talk about the new proposal for an ambulatory specialty model. And finally, I'll dig into some of the requests for information that Medicare attached to this set of proposed rules. Specific to this session, we'll talk about composite scoring overall for MIPS. Then we'll dig into each of the performance categories and any proposals bearing on those, and then anything on the general category of alternative payment models. So let's dig into composite scoring for MIPS. Now, the category weights are unchanged. They're proposing to keep quality at 30%, cost at 30%, promoting interoperability at 25%, and improvement activities at 15%, with all the usual exceptions to that going essentially unchanged. The performance threshold, that is the score above which you expect to be in a positive adjustment, below which you expect to be in a negative adjustment, is proposed to remain at the current level of 75 points through the 2028 performance year. The data completeness threshold, that is to say, I need to report my performance for eligible patients for at least what percentage of my eligible patients for each measure. And that's proposed to be unchanged at 75%, again through the 2028 performance year, and whether it will rise, how fast it will rise after that remains unknown. Now let's look at the quality performance category. Medicare proposes to add 5 measures, remove 10 measures, remove health equity from the list of high priority measures, proposing overall 190 measure MIPS inventory in the MIPS CQM category, 187 of which should be available for traditional MIPS, and 3 only available for MIPS value pathways. They're proposing some basic update to the CAP survey, essentially to add a web protocol with their requirement being that a web survey be distributed, followed by mail to those who don't respond to the web, followed by phone to those who don't respond to mail. And my green dot up in the upper right-hand corner here just indicates my overall approval for these, certainly just to stimulate some thought and some discussion, perhaps. I will either not comment on this or comment on the positive that I approve these changes. Now, quality measures proposed, patient-reported falls in plans of care, the standardized kidney transplant wait list ratio, diagnostic delay of venous thromboembolism in primary care, screening for abnormal glucose metabolism in patients at risk of developing diabetes, and hepatitis C virus sustained virological response. I rated these green. I certainly have, although I'm not passionate about any particular measures here, they seem to represent current standards of care, and these are measures you can choose, and I have no argument with making these available for your choice. Now, quality measures that are proposed for removal: colonoscopy interval for patients with a history of adenomatous polyps, sentinel lymph node biopsy for invasive breast cancer, assessment of mood disorders and psychosis for patients with Parkinson's disease, preoperative cardiac stress imaging and low-risk surgery, imaging for the evaluation of primary headache, perioperative temperature management, cervical cancer screening in adolescent females, and the bottom one, adult COVID-19 vaccination status. Certainly, I have no argument with any of those. I think it represents either a lack of interest in these, sometimes not as don't represent the standard of care currently. Adult COVID, I think we're pooling all the vaccination measures into a single adult vaccination measure. So I think these are all consistent with our previous trends. I do focus a little bit on the proposal to remove screening for social drivers of health, connection to community service provider for social determinants of health. This just seems to me, in light of everything else that's being proposed in this rule, kind of an overall theme of jettisoning anything that suggests a focus on any underserved groups. And I think there's there's a wealth of information suggesting that there are certain social drivers of health that are very important predictors of poor health, and that correcting those social drivers can make a big difference. So you may de-emphasize these. I can't argue with the emphasis that's added or taken away as administrations change, but to remove these just doesn't seem to reflect the current state of healthcare evidence. Last year, Medicare presented a new approach to topped-out measures. Of course, they've been refining an approach to removing topped-out measures from the list over a series of years. Last year, they realize that there's a subset of measures that are necessary for specialties who don't have enough measures, and removing them puts them at a hardship, but they still want to address that topped out state, provide more appropriate scoring, not necessarily limit the score to 7, which gives them a penalty or an inability to reach those positive adjustment levels. So the proposal finalized last year is this proposal to take the scoring approach that's listed there in the table on the right, and this year proposing to apply that special scoring to the measures listed here. So I won't read through them. I'll let you have a look at that yourself in case there's anything there that means anything to you. So remember, not all topped-out measures are going to get that top score of 7. Some will be given the whole scale, but addressed in this abbreviated fashion, just dividing all those score levels at the top end of the scale where scoring is topped out. And it seems quite appropriate. I have no argument with this approach. On the cost performance category, no new cost measures are proposed. Medicare does propose to introduce any new cost measure with a 2-year information only period. So they'll calculate the cost measures. They'll let you know what your performance is on that, but it will not count in your scoring for those first 2 years. They've got some minor updates to the rules for the total per capita cost measure. And there are, and just to review, there are currently 35 cost measures, including 33 that are episode-based and 2 that are population-based. Then the practice improvement category. There are some new practice improvement categories proposed, improving detection of cognitive impairment, integrating oral health, and patient safety and use of artificial intelligence. Proposal to remove some improvement activities, particularly remove the achieving health equity category and add the advancing health and wellness category. Certainly have no argument with advancing health and wellness category. I do, again, object to removing not just the category, but all of the activities that are attached to that achieving health equity category. Again, there's a great body of evidence that shows that addressing those social determinants of health can help improve health. That's some of the person statuses that are associated with inequity do significantly reduce people's access to health care and appropriate health care. And these improvement activities, none of them are required. You can choose what you want. And again, it seems to not to remove credit for doing good things for needy members of your community just doesn't seem to be where we want to be going in healthcare. And here are the practice improvement activities proposed for removal. The one on the bottom I didn't comment on, removing the COVID-19 clinical data reporting. I think is consistent with now that there's COVID-19 is no longer a national health emergency, to let it be absorbed into the overall reporting and syndrome reporting, public health reporting, and other relatively common healthcare practices. Vaccine achievement for staff, that seems to me just to be a very basic good idea to protect your staff members from potentially disabling or fatal illnesses, to protect your patients from you and your staff, and potentially spreading fatal or serious illnesses. And again, as a voluntary approach to that, I can't see why you'd want to remove that. Then all this remove the ability to get credit for activities that minimize disparities, avoid racism, address food insecurity and nutrition risks, create a plan for care for people for non-binary, engage in community resources to address drivers of health, and tool sets to close inequities. Again, it just seems to be a great idea to keep those things there in a profession that really wants to help everybody in the community. Now, on promoting interoperability, some basic changes, all of which I approve. They've updated the SAFER guide. They provided a new version of the SAFER guides as a 2025 edition, and proposed to update the language to require the new edition. They want to add another security risk analysis attestation, or not the analysis of. So the analysis is already there and required. They want to add a security risk management attestation that you've actually taken that analysis and taken it one step further to the management activities. They're proposing to use TEFCA, which was introduced in the last couple of years as a way to meet the interoperability measures, but they also want to use that same infrastructure to offer an optional bonus measure for public health and clinical data exchange. Seems a great idea. And proposing to suppress the electronic case reporting measure. Everyone is now required to be in a progressive, I've engaged in the program, I'm making progress, I've completed the program. CDC is having some problems with that infrastructure at the moment. So until that's back in a progressive state, they're proposing to suppress that measure, which again, all seems to be great proposals. For alternate payment models, the biggest proposal, and again, I don't think there's any reason to argue with this, they want to add back in a method of looking at qualified participant status across all practices that a provider is involved in. They did this to begin with. They Then they discarded that approach, have been only testing at the entity level for the last several years. Now they want to go back to testing at both the entity level and the individual level, and giving all QPs credit for being a QP if they achieve in either of those statuses. As they look at the percentage of charges measure to achieve partial or complete QP status, proposing to use all covered professional services, not just the subset as is currently being done. Again, no argument with that. So remember, comments are due by September 12th of 2025. I recommend that you submit them online in the Federal Register. I give you the link here. When you go into the Federal Register, looking at the proposed rule, there's a green box up at the top called Submit Public Comment. Click on that and enter your comment in the box. There's other ways to submit. You can read about those in the preamble of the proposed rule. But remember, if you're going to comment, you have until September 12th. Medicare does listen to the comments. They respond. It often makes a difference whether good rules are adopted and bad rules are avoided. So read it and comment. Thank you for joining us today. Use the links here on the right to ask any additional questions that occur to you as you listen. Correct my answers if I'm misleading you. Contribute your experience or comments. Remember, we are smarter together. Thanks a lot. See you next time.